Got it. Yeah,
You
I
did
heard
it.
it.
Thank you.
Thank you.
And then the important thing, Dee Dee,
Yep.
it's make sure you don't turn off the computer after the Zoom is over so it can download.
Okay. Thank you.
Hi, Michael. Are you there?
Yeah, I'm here.
How are you?
I'm good.
It's Chris Ogilvy. How you doing?
Yeah, I'm good.
Do you want to share your screen so that we can make sure your slides come up okay? And is it okay if we
yeah.
record you?
Oh, absolutely. It's fine.
Great.
Good.
Let me
Oh, good.
you guys see it?
Yes.
Yeah.
Yep.
Perfect. Thank you. Are you in Australia?
No, I'm actually in San Francisco at the moment,
Oh, you
but
are.
normally I live in Australia.
Oh, this is so early for you.
You're a
Sorry.
good guy.
Oh, it's fine. I mean, I'm
Oh,
used
yeah.
to early middle of the night Zoom calls because or giving rounds because it's always some random hour for me. So.
I know.
Oh my gosh, that's horrible.
I know. I was in Abu Dhabi. I was in Abu Dhabi the other day. You know, you go all over the world. You're in these places all over the world, and it's so bizarre.
Yeah.
Yeah, I one time got up to give a talk in actually Abu Dhabi as well, and it was at 2 in the morning or something. So I said, okay, fine, I'll just tough it out. There's no way they can schedule it. So I got up and I realized I was the third speaker. They didn't tell me that, and the first two guys were 2 hours, so I was like, or an hour each. So I thought, oh, I'll just go back to sleep. So I go to sleep. I got up 2 hours. And the first guy was still talking, and I was like, "Oh man, you guys, just get this better."
Well, that's the thing about in Saudi Arabia and Abu Dhabi, they always go way over their time limit. That's the other, even in real person.
Oh yeah, it's true. Then nobody wants to interrupt the guy who's
The senior guy. Yeah.
Yeah.
Well, it's nice of you to do this. I think Raphael is trying to log on. He just texted me, but he should have the link, right, Z? And then, Mike, some of the logins will be one. It'll be one login, but it's like a conference room for the residents or the NPs, and so it'll look like 10 rooms, but there's really like 10 people in some of the rooms. So.
Okay, that's fair enough.
So where are you spending most of your time now?
I live in Sydney, but I actually spend probably about half my time here nowadays, just doing various things. Yeah. During COVID, obviously, I was locked in Australia, but now that that's up, I've just been here a lot. I've been here for the last month now.
Yeah. Well, one of our partners who log on, Justin Moore, he does vascular and tumors, skull base, and he did a year fellowship with Griff Harsh when he was at Stanford. He did endovascular with us, but he trained in Sydney. He trained in Australia. He's a nurse.
Oh, really? Wow.
Yeah, he's an Australian trained neurosurgeon. So we have the benefit of his quick remarks in Australia. Some of the some of the sayings that we don't understand, and we have to be educated.
Yeah, I the first probably month and a half I lived here, I had to learn Australian English. Now I understand everything they say, but there's just, and the biggest one was when I first got there, I was a fellow, and I rushed to Target to get some sheets because it was about to close and I didn't have any sheets on the bed. And I couldn't figure out how to get the public transit to get there. So I just ran basically, half a mile or something to get to there in time before the place closed. And as I'm leaving, this guy's like, "Would you like to take a trolley?" I go, "There's a train that goes here?" And he's like, "No, that means shopping cart."
Well, I know we're always talking about the record and our call schedule is called something. I still don't know what the roster. We're always on the roster.
Oh yeah, the other is the diary. The diary.
yeah.
So that one throws me off.
Justin makes our roster, so it's important.
Yeah, as long as he switched over and isn't calling it extradural or hydrocephalus, it probably wouldn't throw people off too much.
That's right. That's right. I'll just tell him it should be. It should just boot right up. Here we go. And Carlos is joining. Great.
Right.
Well, Mike, it's nice of you to get up early to do this.
Oh no, it's fine. No, thanks
We-
for having me.
We've just we got into Zoom rounds during the pandemic, and then we've kept it just because it gives our residents a monthly exposure to luminaries as opposed to every 6 months, visiting professor, which we started again. But this way we get a lot better access, and
A lot
the
more
residents get a lot
Yeah.
better. They really enjoy it, and they tell us afterwards that it's really a nice thing, because all the people they're reading about or journals we review, they at our journal club, they actually get to see and meet, or at least online. It's interesting. Bernard Bendock has it set up so that when you're the visiting professor, the night before you have a session with the residents, and then you do the talk the next morning. It's like being a visiting professor. It's kind of fun.
Yeah, that's a new way to do it. Yeah.
It's good. Hey, I see Raphael joined. Raphael, how are you?
I'm good. Thank you. How you doing, Mike?
Yeah, good.
Thank you for coming and joining. Appreciate
Oh,
it.
absolutely. Thanks for having me, guys.
Yeah. Let's see. So I guess we have about a minute.
Yeah. And Raph, you want to introduce Mike, and then sort of lead discussion would be great.
Of
Dr.
course, yeah.
Altman is joining as well.
Great.
Morning.
All right.
Mike is kind enough to join us. He's actually in San Francisco, not Australia, but it's still early morning there. So it's kind to do this without a time shift.
Oh, wow. That's nuts. How much time do you spend over here?
A lot these days. I mean, I'm here. I actually came for the AANS and I haven't left. So
Nice.
yeah. So yeah, I brought my wife and kid with me, and I put them up in a house in LA that we have access to, and we've been basically Americans for the last month.
That's great.
Turn the volume off here.
Yeah.
Well, let's give him time. Raf, do you want to go ahead and proceed?
Yeah, absolutely. All right. So let's go ahead and start. So today for our neurosurgery grand rounds, we have a very special guest, Dr. Sughrue from the Prince of Wales Hospital in Australia. Today we'll be talking about the role of connectomics and in reducing neurosurgical cognitive footprint in the brain. He has a very special background actually in this area, and just to do a little brief educational, a vignette, if you will. Trained, or should I say, at the University of California, San Francisco, at UCSF, where he did his residency and then did a fellowship with Charlie Teo, right, and at the Center of Minimally Invasive Neurosurgery in Australia, there at the Prince of Wales Hospital, where he was professor. And or should I say, he was a director of like minimally invasive brain surgery at the University of Oklahoma, where he took his first position, but then was able to come back in Australia and currently doing work there. Without like too much further ado, I'll just say that, his work in connectomics has been really fascinating. I've been following it throughout the literature, and I'm really glad that he'll be able to talk about it here today, including some work that he's doing with the company. So by all means, Dr. Sughrue, please take it away.
Give me 1 second here. Okay, so thanks for having me. And give me 1 second because I realized there's some slides I wanted to add. Apologize. Okay. There we go. Get to sharing screen. Okay, so as you pointed out, I'm going to talk about how can we do better at achieving better cognitive outcomes for our patients. And as you pointed out, my disclosure here. So when we operate on something, we take something out of someone's brain. What we're really trying to do is to make the scan on the left look like the scan on the right. And I used to tell my residents that if seeing that hole there isn't really fulfilling for you, then doing tumors may not be your career path. And while we're typically able to do this with relatively acceptable results, right, particularly for motor and speech, we're not as good at doing this with a minimum amount of cognitive problems and also mental illness, emotional problems, etc. And part of the reason isn't that we don't care. It's that we don't really know all the wires that we need to save or what we're trying to do to prevent it. And so what we're really struggling with is the fact that when we remove gliomas, no matter how we do this, we're removing part of the brain. And even if we're removing something other than a glioma, we're removing the surrounding tissue around it that's part of the brain. And so ultimately, a lot of times what we were taught was a little bit oversimplistic. So I was always taught that there were the eloquent and non-eloquent parts of the brain, and you wanted to be the non-eloquent. As long as you were there, you could be aggressive and do what you needed to do, and just don't cut the corticospinal tract. And all that is reasonable advice, right? It served us well for a long time. But the problem is that what we have to start thinking about is people have gone, and again, as you can see, I'm somebody who's been talking about supramaximal resection for over 12 years. Does it make sense? It makes sense that taking a margin would be oncologically beneficial. That's true in the breast, it's true in the neck, it's true in a lot of things, right? But the problem is that it really depends on what you're supramaximally resecting. So when adding a lobectomy to some case where you've already cut out the back of the temporal lobe may not have any additional cognitive consequences. When we start talking about things like the motor cortex, we all kind of intuitively know that that's probably not a good margin to put in your supramaximal resection. But again, the other question is it worth getting a margin or even 1% more of the tumor when it comes at the cost of changing someone's personality or leaving someone really in a terrible neurologic state from a quality of life standpoint? And I think it's another thing that we have to take a step back when we start talking about taking margins or supramaximal resection or whatever you want to talk about it, that we're not as good as we think we are in the cognitive domain. So when we talk about neurosurgical perfect, it's possible to have a patient who's moving all four and talking, but has horrible depression, is a different person, ending in chaos in their life. And particularly for low-grade gliomas, this matters. And so if you look at this paper that I helped co-write with a team at Penn State, what they were looking at was how often does someone have a new mental illness after glioma surgery? And the answer is somewhere between 70 to 90%, depending on where your source is. This is really high. And we also know that if you were trying to drop someone's quality of life intentionally, the best way you could possibly do this is cause depression. It's actually, for a self-perceptive quality of life, it's actually better to be bedbound, but otherwise not depressed, than be mobile and depressed from how you perceive your quality of life. And so ultimately, we're not as good at this as we think we are. And when we start talking about the term oncofunctional balance, we have a really difficult thought process. So it's always great to say, let's get more tumor out. And if you don't control gliomas or some cancers, what you're talking about may be irrelevant, right? So if you look at this patient on the left, if you do a biopsy of this and then radiate it, thinking that what you're doing is avoiding a subtle cognitive problem, well, the cognition is going to be bad. So you're going to you have to get this tumor under control, and that may involve being aggressive. On the other hand, if you sit down and push the resection boundary deep into the internal capsule to try to get 1% more of the tumor, it's hard to say that this is a great trade-off that most of us would actually do to ourselves. So the bottom line is, it's hard to give a hard answer on this. And this is why neurosurgery is difficult. We have to make tough choices, and we don't have all the facts. Particularly, we don't have the facts about how the cognitive system in the brain works and how do we do minimal amounts of damage to it. And so I don't have all the answers to this right now, but it's something that I've thought a lot about. And I want to outline some ideas and steps that how we as neurosurgeons can get at this problem and eventually start to do better at it. So the first recommendation that I think I can safely make now that is probably true, and we're gaining increasing data to say that it is true, is don't cut through the center of large-scale brain networks. So I'm going to spend a little bit of time talking about this. The second is we can start thinking about the brain as a global computer and really maintaining its topological organization. We can also start to use AI to get at individualizing circuits. And finally, we can consider the possibility that we can utilize techniques like non-invasive brain stimulation to change the connectome in our favor. So when you say a network, what it means is that it comes out of a term from neuroscience, and what people have realized over the last 15 years is that there are parts of the brain that are not immediately next to each other that have highly synchronized activity. It doesn't mean they're exactly the same, but it means that if A is firing, then B usually is firing more often than not, and highly correlated. Generally, as we've really dove into the anatomy of this, it generally is because they're directly connected, and often because they're doing something very similar to each other, so they frequently fire together. Now, if we study this for the whole brain, we get a map that looks like this. And how you create a map like this, what you basically are saying is, you tell the machine learning, give me a solution where you assign the voxels to whoever is the closest area to them. So for example, if you look at this map here, the sensory motor system creates a single unit where the motor sensory cortices are really talking to each other most of the time. And that's not very surprising. The visual system, not surprising. And an limbic system, also not very surprising. What's different to neurosurgeons is that the frontal lobe has a large network called the sensory executive network. Another part of it's the default mode network. This pink network is the salience network, and the green is the dorsal attention network. And really, this architecture has really been elaborated over the last 15 years or so. So some of these networks weren't even discovered or known. There wasn't a name for them until the recent years. Even some of them around the time I finished my residency. Now, if we go into the machine and we decide to solve it a little differently, these networks subdivide. So let's say we tell the machine, instead of tell me who the 7 closest neighbors are, we do the 17 closest neighbors, and we get this. Now, if you look on the left, the default mode network breaks into 4. There's a core network, which we best call the canonical default mode network. But notice that the language system is part of the global neighborhood of the default mode network. So it's closer to the DMN than it is to anybody else, but it's closer to itself than it is to the rest of the DMN. And you get a network that looks like this on the right. Now, if you get down to it, this looks very chaotic. There's all these splotches around this. And the bottom line is, we've done really deep dives into why this map looks like the way it does. And if you unfold it to the embryonic neural tube, where you trace it in evolution, it actually is completely orderly. So for example, if you look at the parietal lobe and you compare it to the temporal lobe, you see that there are these kind of standard organizing repetitive units. And again, this really highlights that these networks are the organizing principle of the cerebral cortex. But again, it's hard to, if you look at that map, it basically tells you that everything is off limits because everything is part of a network. Everything's doing something. And we know that we can do surgeries in the brain and people, some people are fine, right? What we really have to say is diving into this, what are the places that in general, it would be best to do whatever you could to preserve it if at all possible. Doesn't mean you can always do that, right? So if for example, if the default mode network is full of cancer, you may have to make a difficult choice. And that comes into the realm of informed consent. We sacrifice function sometimes for oncologic benefit. But the difference is that if you have the option, it'd be better to not cut through it if you could. And we should at least be thinking about some of these things because they do have consequences. And so we basically dove into the literature, spent a little bit of time looking at this, correlated this with some of our own experiences and the experiences of people who are early users of software to show this kind of networks. And essentially, we've come up with this concept called the non-traditional eloquent networks, which is, or AKA the big five. So these are networks that the literature says that if you destroy them, you probably are going to cause some kind of issue that's non-trivial from a cognitive or emotional standpoint. So the top three are the control networks, and the bottom two are the attention networks. Now, I'll go into the anatomy in this a little bit. One of the things that many of us really have to realize is that technically when we do an image like DTI or resting state fMRI, we get these really beautiful pictures that people use for talks and grants or to advertise their department or whatever. And they look great, but the problem is they're really, really complicated data sets. And there's a lot of fibers here. And it's hard to know with the naked eye where all these are going because really the human brain is not very good at solving extremely complex problems like this. So we kind of might recognize the cortical spinal tract or the arcuate, which is nice, but there's a lot more in there. In fact, everything we're talking about in cognition is somehow wired up in here. And when we try to solve something really complex, humans are bad at it. Artificial intelligence is pretty good at it. And when we start looking at fMRI, right, we've known for a long time, and probably everyone here knows that you can do an fMRI and show language or motor function or other things. But what really is new to a lot of neurosurgeons is the idea that you can actually don't need a task. You just have the patient lay there. The parts of the brain that are doing these things talk to each other pretty frequently. And you can, essentially get, if you use the right statistical methods, a ton of information about brain networks and how they're working without having somebody set up a computer screen in the MRI and take an hour and all the things that we associate with the difficult logistics of task-based fMRI. And resting state fMRI is much more scalable. We can get this on basically anybody. It's like ordering a flare. But the problem is when we look at that crosshairs, you can see that there's this bold signal waveform, and that happens simultaneously at 100,000 places in the scan. So again, this is not something very useful. If I give you this and say, hey, determine whether you need to place an EVD, it's not really going to give you any insight into that. But machines are pretty good at doing this. And what we know is that when you're dealing with million-dimensional data sets, or in this kind of big data, that you have to do dimensionality reduction of some kind. You've got to cut this down to something that's tractable, or otherwise it's just, we never get enough power, or you get the curse of dimensionality, et cetera. And there are a lot of ways to do dimensionality reduction, but the best way that we know is to utilize outside information, meaning having a prior. And one of the best priors that we have for studying the brain is parcellation. That's when you take the cortex and divide it into parcels based on what they're doing. So and we all know at least one parcellation. It's called Brodmann's areas. Brodmann was the first person to parcellate the cortex. He divided it up by cytoarchitecture. This is actually my brain with the HCP, Human Connectome Project Atlas, warped onto it. And when you see a color change, that means that that boundary indicates some change in function. It may be subtle, it may be profound. But one of the things when we started looking at this paper when it was published in 2016 is that it's very interesting and insightful. So for example, if you look at the insula in the upper left panel, you can see that there are areas that are tucked into the cleft of the undersurface of the opercular cortex. There are areas that cross onto two gyri. So the thing we realized was that there was a lot of potential in utilizing a scheme like this to describe brain anatomy. Most importantly, the brain does not care what we call a gyrus or a sulcus. What's the evidence seems to suggest is that the gyral and sulcal patterns that we see in an individual are really just a feature of the cortex doubling over itself as it thickens in development. And it does that are based around certain white matter pathways and the physical boundary of it. And so that really has no relevance to how the sheet is organized. The sheet has generally fairly consistent organization between individuals with some variability. But the more important thing about it is this gave us a much better nomenclature than saying the superior temporal gyrus to describe a function and to be able to replicate each other's findings, which is essential for science. So if I say, hey, this area 8C or 55B is part of the network, you can confirm or deny that. So as a neurosurgeon, I took this approach a little differently. And what I really just wanted to know was, where are these areas? What are they doing? And how do we stay out of them if necessary, or what do we cut? And so I did anatomy. And obviously you can see that that turned into an entire issue of neurosurgery. And once we got that, we studied that, what we were really trying to do is say, how can we apply this clinically? Because I can, demand that everyone understands 360 areas before they really think about connectomics. But that's not really, again, something that's scalable or practical, or, we can't have a 3-day rote course to remember 360 cortical areas. So in order to really take advantage of connectomics and bring it down to a clinically applicable standpoint, we have to be able to take an atlas, register it to the brain, and know where Broca's area and all of the other areas are. And as you can see, in a normal person, that's fairly straightforward to do. There's some nuances to how you align the atlas. But when you study something like this, those atlases aren't really accurate. And particularly if you have a hole in the brain, which is a good portion of the patients I saw in my clinic, it's really not going to work very well because you're violating the assumptions of a registration program. So what we came up with was an algorithm that essentially, what it does is it looks at the connectivity of an area, for example, Broca's area, and it doesn't make any assumptions about where Broca's area is located. It just looks at who each voxel is connected to. So for example, this guy looks like a Broca's area voxel because it talks to Wernicke's area, and this guy does not. Now, in a normal person, it's going to go around reassigning about 3 to 5% of the voxels, which is roughly the individual connectivity differences of the connectome. But if it sees something that's nearby that fits Broca's area, it's going to move Broca's area's boundary to fit that patient's anatomy. And more importantly, if there's a hole in the brain or there's a tumor where there's no tracks, it doesn't assign anything. And what this allows us to do is to map really, really distorted, crazy brains, sort of like this one, where we've removed part of the frontal lobe. There's a glioblastoma that in a previous operation, the GBM is back. We didn't even offer surgery, but I dutifully taught my residents to order DTI on everyone, so we had it. And I put this into the algorithm to see how it performed, because I said if it could do this, then it's believable. And you can see that even though the insula is shifted very far forward on that upper left panel, it knows where the basal ganglia is, it knows what's missing, it knows where things are. And that allows us to make maps of networks. So for a long time, we've known that this is a bad tumor. And number one, it's going to hurt the patient. The patient's going to have declining cognition. More importantly, if you operate on this and you don't really know your anatomy and you just go in this blindly, there's a high chance that you're going to make the patient significantly worse. But why? Because we cut the corpus callosum all the time. So why do callosum tumors cause these kind of symptoms when this isn't what the spleen of the corpus callosum does? Well, some of it's the fact that this particular tumor is dumbbelling into the language and motor systems, but not all cases do. There are cases that are just in the corpus callosum. And no matter how much it dumbbells into the brain, essentially all of them are either close or wrapping around the default mode network, which is part of one of the epicenters of human cognition. So it's not surprising that if you destroy this or the tumor destroys this, the patient's worse. In fact, this particular area has a role in episodic memory. And so we can start to have clear answers for why the things are the way they are, or at least it's answerable. We can use our, clinical research to sort of really describe anatomy and be more confident on why things are the way they are. We can also start to think about tumors a little differently. So instead of saying this is this blob in the insula that I'm going to make a hole where it used to be, we can start thinking about the reality that we're actually making cuts next to networks, and that this is an anatomical resection to trying to preserve whatever the network anatomy that is involved in this case. More importantly, when we see a really bad tumor like this, we can have a real discussion about the risks and benefits. So instead of just saying this is bad, it's inoperable, or I'm going to go and debulk this, we can start to look at the fact that not only the default mode, but the salience network are draped all over this tumor. And we can know what the likely consequences will be if we injure them and what the probability of injuring them. So we can have an intelligent discussion with the patient and say, well, what is the benefit of getting some of this out? And what would be the challenges to removing all of it? And again, have more informed discussions. But also, if we decided to do something and try to take some of this out, what would we do? So we spent a long time working with the connectome to annotate the connectome, kind of analogous to annotating the genome. And what that basically means is figuring out what these areas are doing, what network are they part of, and how do we use this information to build up to a better understanding of what the brain is doing, and particularly how can we infer this in patients who have tumors or other problems like we just described. So what you can do is take the task-based fMRI literature. You can basically create a Gaussian distribution of where the points in the literature for, say, language are. And what we can then do is say which parcels live in that Gaussian, in that region, and ultimately make a map of a network. Now, you can see that this is the language system, and it's not just the Broca-Wernicke model. There's a lot of other areas that play roles in language. And ultimately, if you look at the right panel, there's a thing circled called 55B. This is the evidence is really strongly pointing to this being a motor cortex for the larynx. And we've seen patients who've had neurological deficits. I've seen other people's patients who we found out had neurological deficits from hemorrhages in this area or surgeries in this area. And so we're still learning about areas that do speech and motor in 2022. But what's really more interesting is when we start to get into how do we understand the cognitive system of the brain. And I could spend hours and hours going into all the things that we've learned, but I think the one that I try to leave behind with people are the control networks, because we know they're important, and they're generally new. Oftentimes I'm the first person telling many of the people in the room about these networks for the first time. So if you look how the default mode network and CN work, they basically are organizing your cognitive workspace. The DMN is the network that's on when you're thinking to yourself. The CN is when or the executive network is when you're doing something externally. And the salience network mediates the switch between these two networks. And this is well studied. So while these things are new, there's thousands of papers at this point about what they're doing or their roles in different diseases, including mental illness. The DMN's core, again, this isn't the whole DMN, but it's the core. So these are the most strongly correlated areas, are an anterior cingulate, posterior cingulate, and lateral parietal network. The salience network is a middle cingulate anterior insula network, and the CN is this kind of multi-part network going through the frontal parietal and temporal regions. Now, as I pointed out, these aren't new to neuroscience. They're just new to neurosurgeons. We know a lot about what they're doing. We know that mental illnesses involve areas of these networks talking to each other in abnormal ways. And again, it's becoming increasingly clear that destroying them causes problems. But one of the real power I find with diving into connectomics is we can start to learn things that we kind of have always been taught, but we never understood exactly what the exact place the problem was. And so we've known that the medial frontal lobe is a more dangerous place than we really given it credit for, because we know that if we have for example, bilateral ACA stroke, that this is not compatible with quality of life, or even a unilateral injury can cause some significant blunting or abuli in people. But why? And what does it mean to make someone, quote, bifrontal? Because you can operate sometimes in both frontal lobes if you have to, and not everyone's akinetic mute after this. But when you realize that there's a strip, it's like kind of like instead of the motor strip, the initiation strip going from the default mode network along the salience network to the SMA. And in fact, the SMA is not really a motor area. It's mostly salience and DMN meeting in a certain place. That's actually true with all the motor planning regions. Then you get an idea why this would cause a problem. And actually, if you look at a paper from your institution, they found that if you look at people who have akinetic mutism, the injury pattern that you're looking at, the network disruption, is very strongly related to this system. So again, it highlights that this is probably, we should be considering this eloquent, even though it's not a part of the Spencer-Martin eloquent score, because we didn't really know what the anatomy of this area was before. Now, zooming ahead in the interest of time, what we have to recognize is even though we don't see the anatomy, we don't see this stuff when we're operating in the brain, it has anatomy, it's still there. And if you cut across it, it causes problems. And it's not, while not all fibers in the brain are untransgressible, the brain didn't evolve the frontal lobe as a CSF sponge. It's doing something. And in order to try to think through this problem, we have to really realize what the real power of tractography is. We've had tractography for a long time, and I've used it for thousands of cases, or at least 1,000 cases. And what we have to dive into is, what does it do and what are its weaknesses? And what it does do for us is it tells us, hey, this is the center of something that may be connecting a lot of areas, and you can rack up a lot of damage in a small area. So tractography tells us that, but it doesn't tell us what all these twigs are doing. And one of the problems is that when we start talking about what are the cortical regions we need to preserve, when we get to areas that, like higher cognition, that are hard to map interoperatively, particularly in patients with glioblastoma, then we have to know which one of these are being preserved. What needs to stay connected to what at the end of the operation, and tractography just can't tell us that. But when we have a map of a network, it gets a better model of where the cortical and subcortical things that need to remain connected for this network to maintain integrity. And it gives us a better idea of where we need to put our line in the sand. It doesn't mean that all these cortical regions are mandatory. We'll have to figure that out over time with clinical research. But what it does tell us is that this is how the language system is organized. And if you try to think, why should we put these lines in the sand? What evidence is there that saving a network or saving these particular networks is better than not saving them? Well, as I pointed out earlier, evolutionarily, embryologically, and functionally, networks are the organizing principle of the brain. And we know that cutting neurons in the central nervous system tends to eliminate the function of whatever that thing's doing. So if we cut the corticospinal tract, has a pretty clear link deficit. And while the cognitive tracts tend to not have as obvious of a problem that's easily in binary, has a binary definition, it's pretty easy to use inductive logic to say, well, we don't have RCTs on cutting the optic nerve or the spinal cord, but that seems like a bad idea. In general, if a network is doing something strongly, then you might lose that function if we destroy it. So this is where we got into the concept of the big five. And part of the reason we use those as a defining line is that these were the areas that we could find in systematic reviews have the most evidence, and this again spans 550 papers, showing that destroying or damaging one of these networks or causing dysfunction, and even from a disease state, causes a observable cognitive or emotional deficit. And what we looked at in this study was how often in insular gliomas do we encounter this? Now, eloquent regions are fairly common if we're doing insulo-opercular tumors. But when we operate around the insula and the sylvian fissure, pretty much every case we're encountering one or more of these networks, usually multiple networks. So ultimately, we've probably been cutting across this for a long time. So it shouldn't be surprising that we have subtle cognitive problems and depression in a large number of our patients, because again, mental illnesses like depression are dysfunction of these networks. So if we're destroying parts of them, this may have unintended consequences for how these networks work. And so again, what we have to realize with interaxial surgery is that while it seems simple compared to skull-based surgery, and skull-based surgery is difficult, we know that, right? There's one advantage you have in skull-based surgery is that the anatomy is visible. So you can see everything, And there's really very little chance that someone is going to discover a 13th cranial nerve that we've been ignoring that causes problems. We kind of know what's there. Whereas in brain tumors, intraxial tumors, you know, the default mode network is actually running through the slide, but we don't really see that. Even if we know that the cingulate sulcus is a particular location, we need to put anatomy back into the surgery, and adjuncts can help us do that. So what I was trying to do in this book was to first start out and say, if we had to do something, remove the frontal lobe, remove the temporal lobe, what is the safest way to do that based on our understanding of networks? What's the minimally disruptive network approach? So we kind of outlined this. And more recently, we got a product cleared through the FDA that essentially maps these networks and puts them onto image guidance. So you can see there's the central executive network. Now, as people have begun to get experience with it, and I hop on calls with people all the time to kind of get them through the, you know, what are you looking at? Because it's new to most people, you know, experienced tumor surgeons to private practice guys, everyone is kind of new. But what we find a lot of times, and it's surprising to people, is that the shortest path is sometimes the wrong path. Sometimes that, for example, in this case, the shortest path takes you through the middle of the dorsal attention network. And sometimes the longer path is a better path. But also what we oftentimes find out is that, well, you know, here we're going to have a serious discussion about oncofunctional balance. What are we trying to accomplish for this patient? And what that really changes how we think about a tumor like this. So, you know, 10 years ago, we would all thought, you know, I would have thought about this as this orb that I need to put a hole there, right? But the fact is this: what we know is that there are networks running around the tumor, some cases partially through the tumor. You see the default mode network is, and so instead of thinking this like an orb, what we actually think about is a set of cuts. If we make these cuts, we're going to keep the networks attached to themselves as much as possible. And as you can see, this is a very aggressive resection. This is not a biopsy. We're not usually discussing biopsy versus gross total resection. We're discussing leaving a little bit in the basal ganglia and a little bit in the medial cingulate to keep the network as functional as possible, but still removing a large piece of the tumor. And I think that's the real, you know, take home point, is that it's not about leaving a bunch of tumor in the head. It's about making intelligent decisions. And more importantly, if anyone would go after this part of the basal ganglia and in default mode network, then obviously you've got talents that I don't have. But if you get down to it, it's really trying to make an intelligent choice about what needs to stay and why does it need to stay. Now, saving networks is a good idea, but there may be cognitive effects that can't be picked up by this paradigm. So for example, if we look at mathematics, and we've mapped math, so we know what parts of the brain do it, we know that it involves multiple networks talking to each other. And so if you try to think, how do you prevent all, you know, like keep all the networks talking to each other, you can't do surgery. And so what we try to think about is how can we utilize more sophisticated techniques to say, well, we can't keep everything connected to everything, but they might have alternate ways to do it. And we need to maintain the brain's overall architecture. And this is where techniques like graph theory become useful. So what graph theory involves is a method for studying extremely complex systems of interactions and learning things that may not be obvious to the naked eye. So you make the brain into a graph, or really make it into a math equation by taking the DTI, parcellating it, and calculating everything that connects to everything else. Looks like that. And so a couple things you can learn from it. One thing you can look at is who are the hubs of the network. So for example, who's the most connected parts of this. So the shaded node on the right is a bigger hub than the shaded node on the left because it's connected to many things and more important things. But if you do that analysis for the brain, we asked who are the hubs, because hubs seem to be important. They're use different genes, they use more energy, and they are more susceptible to Alzheimer's disease. But who are the hubs? And we studied this in a lot of normal people, hundreds of them. And if you were basically grading an AVM, these of the top 10, these 6 get you a point in the Spencer-Martin scale. And I would argue these probably should, given what we know about them. So hubs really are a synonym for eloquent, or vice versa. Eloquent is a synonym for hubs. And so, yes, cutting through a hub is more likely to cause an observable neurological deficit, and areas that are primary areas tend to be hubs. But how often do people have hubs where we don't expect them? So this paper we published a few years ago, I'll get to the gist of it. And we did a big machine learning approach on this and found that about 7% of people have a hub in an unusual location, like the frontal pole. And so are these the people that we do a surgery on? It seems like a minor like biopsy, open biopsy or something, and they just have all sorts of complaints from that. We don't know. Another thing that could possibly be explained that is a concept called path length. So let's say I take a graph and I say, well, that turns to be the shortest path between those 2 points because it's going down the biggest fiber bundles. Now, path length is interesting because the shorter your average path length in the brain, in general, it correlates strongly with having a higher IQ. So we raised the idea that, well, doing that may lengthen your path and it may have an effect on your efficiency and overall cognitive reserve. And so we studied, what do we do when we do surgery? What are the bad surgeries, and can we figure out this ahead of time? So what you can do is you can basically take a graph, make a graph out of the DTI, and you can calculate global efficiency, which is a measure of how short are your paths. And then what we did was we created an algorithm that did all reasonable brain surgeries. So we didn't do things on, take out 2 parcels on opposite sides of the brain or something unrealistic like that. We wrote the algorithm to only do things that were in continuity with each other. And we did that to the graph and we calculated global efficiency. We basically ran every possible operation that was plausible in the brain up to, obviously remove the whole brain, but up to lobectomy. And what you can see here is this is the result. So everyone's brain looks like this. Every lobe of everyone's brain has this sawtooth. And what the sawtooth basically is, if you look at each line, that's a different brain surgery. And what you're measuring is the global efficiency. So as you remove more brain, that global efficiency slowly drops. Now, what's interesting though, is that there are operations that you can do that are worse than removing more of the brain. So in this particular sawtooth, those operations on the left actually are worse than if you remove 5 regions somewhere else. And we dove into this. It took us almost 2 years. It's very complicated, but I'll basically highlight that there are individual differences. There are not infinite numbers of differences in what the worst surgeries you can do for people. In general, most lobes have 2 to 3 patterns. We call them connectotypes. And essentially, if you were operating on person A, who is the red connectotype, you would actually want to, if you're taking a trajectory, go to the other place because it would be less damaging. Now, what we started to get to is, can we study function and make sense of it in a way that actually individualizes this? And as I pointed out with resting state fMRI, you don't really necessarily need a task. And as you're sitting there laying in the scanner, different parts of your brain are activating in different combinations. And the big so what about this is that when we start to quantify this and we start to look and say, how often are different parts of the brain talking to each other? Well, there's things that are predictably should be synchronized. So if these 2 parts of the brain are part of a network, they're going to highly correlate with each other. You can see that's in red. But what starts happening with disease states, and this has been shown in really thousands of papers at this point in many diseases, is that parts of the brain begin developing abnormal functional connectivity. It means the correlation is either too high or too low compared to normal people. And this is really the link between, the phenotype and the biology. And so, for example, this paper here shows that, and it was published in Nature Medicine in 2017, they were looking at people with depression. And what they found when you look at the functional connectivity and resting state is that you can distinguish as many as 4 different subtypes of depression that have different symptoms and different responses to treatment, which means they're basically different diseases. And so one of the challenges, though, when we start looking at connectomics is these data sets are vast. So if you really look at the fact that every little red dot is showing something that's either correlated or not correlated, and every single one of these these little boxes are networks, it really becomes very daunting at first of how do we even find anything in this. So we built a hypercluster processing tool that was aimed at answering questions that were clinically relevant out of his. So for basically linking the clinical data to the connectome and mining it at big scale. We're capable of processing 1 million scans an hour. And what you're looking at here is a auto machine learning pipeline where the machine learning is running every possible setting till it maximizes the area under the curve. And what we are interested in doing is saying, there's things that we care about knowing. Can we find a representation in the connectome that answers the question? So for example, if we're taking a disease like schizophrenia, where there's 35 different symptoms, can we find what place in the brain, what circuit or circuits are relevant to those symptoms? And often it's multiple circuits. Because if we can figure it out where this is located, we can possibly do something about it. So we took machine learning and turned it around a little differently, because we don't care about the machine doing our job for us, because we're not good at this job. What we want to know is, how does the machine figure this out? And what we get on the left is a readout of the hotspots that explain this. And so you can see that, not surprisingly, hallucinations come from the auditory cortex, but we can start to learn that things like negative symptoms and more vague symptoms, like the fact that somatic sensation comes in the insula, and this is part of the salience network connection. And this really gives us insight of things that we might be able to do down to the individual symptom level. And so again, this is a tool that we're building out for FDA, and really trying to bring into the real world. And what we can do with this kind of stuff is start to take rehab more seriously. Right now, rehab, when I trained and for a long time, was you send them to the physical therapists and the PM&R people and hope that they make them better. But of course, what we know now is that there are safe and effective brain stimulation techniques like TMS that have a long track record, lots and lots of randomized controlled trials showing their safety and efficacy. And increasingly, papers like this one that we wrote showing that if you treat patients after craniotomy, it's not only safe, there's concern that it would cause seizures in everyone. We have never seen any evidence that that's true. We never had one in many patients that we treated. More importantly, is that you can at least speed up the improvement of a neurological deficit, which for people with gliomas who need to get an adjuvant treatment, this is a very big win. And essentially, TMS kind of is a paddle that delivers a magnetic pulse to the brain. You can see that the field it delivers is somewhat wide, but reality, the biologically relevant part of it is the red area. So generally, you have to be over the correct part of the brain to get the effect that you're looking for. And however, when you do that, when you get it right, you can often make a substantial impact on people. So you can see here that this is an RCT that was published last year out of Germany, and you can see that what they were, if you give TMS to a patient who's hemiparetic, starting after surgery, the cohorts diverged very quickly. In fact, the number needed to treat was 2 in this study. So this is something we really need to start taking seriously, because we can substantially speed up our recovery, but it also opens up numerous possibilities of how to treat patients. You can see this is a case that we treated in Sydney. You can see, again, this isn't the surgery. I did not do the surgery, but the patient wanted a very aggressive operation, so this is what they got. And we were asked to come in and help rehab this guy. And rehab, not just meaning get him out of bed, but to actually make an active plan to take over his rehab as a neurosurgeon, use an image-guided procedure, stimulate. You can see that he's got pretty substantial weakness. The hand is mostly better at this point, by post-op day 7, but you can see that essentially she's telling him to think about moving his leg, because at that point he's plegic. This is after 1 day of treatment, so pretty fast recovery, where he's now able to weight bear. Again, this is by day 2, and he's a surfer, so what he wants to do is get back to surfing. Now, taking out something out of the motor strip and surfing a month later is generally not always a realistic goal. But you can see by day 5, he's regained a substantial amount of function. Now, it's possible he would have got there on his own. We don't know. But certainly getting this much function back in 5 days is pretty fast. And more importantly, it gets him ready for additional treatment and make sure that he has good quality of life. And you can see he's got pretty good function. Okay, so how do we decide where to aim this? And so we need to look at things like the structural connectome. Obviously, we can't regrow the cortical spinal tract if we cut it. We've started thinking about this ahead of time. So if we know that tumors involving a network, we prepare the patient for the possibility of having a deficit and prepare the rehab. We start thinking about what can we leave behind that we can stimulate. But also we then look at the functional connectome, because many times these patients are not hemiplegic or aphasic because the tract was cut or you caused a stroke. It's sometimes because there's dyssynchrony in the network, and that's actually fairly quickly corrected with TMS. And so we can start to look at the functional connectome like this. So you can see these are the language areas. The red squares highlight that something's highly correlated, and that's because language is a network. It's supposed to talk to itself. That's why it's in red. In the right, you have a patient with a glioblastoma in the arc fasciculus, and the reason it's blue is that the areas aren't talking to each other anymore. Now that's pretty cool that we can see aphasia on a graph, but that is that part of the brain, area 55B that I talked about. And what we can do is pull out a target and stimulate it, put on image guidance. Now, this is a patient we did that to. She's 18 months out from a pretty good sized MCA stroke. And while she's young, she hasn't seen improvement in a long time. And you can imagine the deficits she has. Her speech was present, but it wasn't normal at all. She's pretty impaired. And what we did was look at her structural and functional connectome, and I could go into this in detail if people are interested, but essentially the only thing that was still connected to Broca's area that we could tell was the right SMA. So we saw that little fiber bundle. So we stimulated that. It also had disc activity. And you can see that 4 months later, the fibers actually look thicker to us, but more importantly, she's actually able to in college because her language improved so significantly. So this really highlights the fact that we could be doing a lot more with the existing tools we have if we know really how to think through a case this complicated and have a reasonable target. So what you can think about is the idea that we can look at the structural and functional connectome, flag anomalies, look at the connectome, decide what we don't like about it, and change it with machine learning. It really opens up a real whole field of what we can do for patients. So thanks, everyone.
Thank you so much, Mike. Really appreciate that talk. And there's so much that I've actually learned, about different pathways, as you mentioned, as far as like BMN, et cetera. So one thing I wanted to ask you, for example, right off the bat have you noticed for some of these, like the salience or DMN, et cetera, is there like dominance, and does that affect like how one would perform surgery in these regions?
That's a good question. The answer is we've studied this a bit, and we're not certain that the results are 100% reliable, but most people do have some dominance. And what's more interesting is I was at the Barrow, and I was talking to Michael Lawton and the group there, and they said, well, how do we know that these networks are, if you cut through them, they're bad? And I said, let's do a study together. So we did. And not surprisingly, we had machine learning look at all the patients they had that had some kind of significant issue, meaning the Rankin dropped. It's not that many people, but they had enough data where we could actually do a machine learning model on it. And it flagged the networks. It flagged the dorsal attention network. It flagged the DMN. It flagged the salience, but it didn't flag all the parts on both sides. So that could be because we don't have enough data. It could also be that there's a laterality that matters in some people. That's a question that we have to dive into deeper. Obviously, we know that the left SMA has different consequences than the right SMA. We also know that people have contralateral connections from the other side that can often take over. So, for example, if you remove the DMN and cut the corpus callosum, it tends not to get better. We published a paper on why that is, which is the other side has a direct connection to Broca's area, for example, but it's not symmetrical. So these are these kind of questions that how do we discern dominance, particularly when there's a tumor? When can we get away with it? That, again, we need to organize study groups and really get at this. But what I would say is that probably not all parts of all networks are equally important. And we have two, so there may be some people who are completely co-dominant and other people are really dependent on one or the other. And this is just something we're going to have to learn. We didn't have the ability to describe the brain this way. So it's sort of like when the MRI came around and you could publish a paper saying, oh, hey, this is what meningiomas look like with contrast, and get it published in HNR or something. We're at that phase where just describing what you see can be very valuable.
True. And another thing to follow up a little bit different is when I do DTI for some of my cases in eloquent regions, I find that the edema and swelling from the tumor kind of affects that map. How do you find that in your, current situation with your connectomic maps, and et cetera?
So there are algorithms that will actually extract the free water out of the scan. So we have them, and essentially, it's really complex math, but it borrows some things from Einstein's theory of relativity about Riemannian manifolds. But the bottom line is, from a practical standpoint, the free water and the interaxonal water that you're actually trying to measure actually have slightly different properties. And so what you can do is you can actually compartmentalize the water into a gray matter, a white matter, and a CSF. And then essentially you can develop an optimization algorithm that just maximizes the distance. And then you just set everything that's not inside of a cell to 0, and you get the edema out of the upper thing. It works pretty well. I'd say 95% of the cases we've seen, tracks going through the middle of a glioblastoma and edema. There are some cases, particularly Mets, really bad Mets, that you still see a little bit of washout, but it's a lot better. And so we're continuing to optimize that algorithm. It's non-trivial, but we have a new update that we think will actually even push that further. So it's not 100% perfect, but what it does is it gets rid of that blind spot right where you care about it.
Yeah.
And so that's, I think, one of the big things is free water elimination. Tractography algorithms are a substantial step forward for us.
Sure. And my last question, even though there's a few more, but one is, given your history, and I've really enjoyed a lot of the papers on supramaximal resection, and pushing a little bit, how do you find now using this type of approach? Are you cutting back a little bit on the supramaximal work, or also how do you counsel said patient about, like cognitive changes based off of all this new data?
I think, well, yeah. So the first is yes. I think that just like everything, if you tell a patient that you're very likely to have facial palsy after this operation, or it's a high risk, and then it happens, they're a lot more understanding than they just get that surprise at the end of it when they wake up, right? So people don't like surprises, but everyone hates bad news, but nobody likes the surprise. So I think it's really valuable. Having said that, you also have to pitch the other side, which is tumor resection matters. And you really also get down and say, well, okay, how much does it matter? Are we talking about leaving half the tumor? Or are we talking about if I save this one node of the CN? Or are we talking about this is the difference between me getting a beautiful scan that I show at a talk versus a not so beautiful scan? And I'd rather have not so beautiful scans than living patients, and functional patients. Having said that, I think one of the things about it, you think about it with supramaximal, is that it's a principle that sometimes is appropriate. And where it's appropriate depends on, okay, for example, if you're not getting a gross cell resection of the tumor, don't take margins up against the network. That doesn't make sense, right? Second thing about it is, if you've basically made certain cuts in the brain, like for example, you cut the back of the temporal lobe to get to the tumor, in many cases, you've already cut all the connections to the temporal pole. So there's no real, as far as I can tell, a reason why you would save it. You could just add a lobectomy, because at least you shouldn't recur in the middle of the temporal pole that's not connected to anything. So, and the frontal lobe and occipital lobe have situations like that. I think part of it is incumbent on us to understand enough of the anatomy to say what is actually going through there. And I'll give an example. Like if you look at the frontal lobe, let's say you were going to cut really all the way down to the ventricle in the back of the temporal lobe or frontal lobe, and you say, okay, I'll leave the CN, fine. It's not near there, the DMN, but I'm going to cut everything in between those two. And I've done that many times and generally reasonably well tolerated. But if you're going to do a supramaximal resection, you shouldn't cut the orbital frontal cortex, A, because it doesn't really directly connect to that. It has a whole different connection to IFOF. B, it has consequences, particularly on the right side, for judgment and behavior that are non-trivial. And so the superior polar region, you've already disconnected it from the rest of the brain for all intents and purposes. So what is it really doing? On the other hand, that is not true for the orbital frontal cortex. So it's thinking intelligently about how these parts of the brain are really wired up to say, well, what is a good margin to take because there's no consequences versus a not good margin. So again, leaving a hole in the frontal lobe where there's some, disconnected polar region. Why? Just take it out. Like, don't have it recur there. But on the other hand, you have to really think about every single area and really understand what is that connected to, and am I already disconnecting that anyway in the course of taking out the radiographic lesion?
Yeah, thank you. Of course, I could open it up to anybody else that has questions too.
I have a question. How have you found that the connectome has influenced like your less of that and just relying on the imaging data, or how have you found that interaction?
Sorry, you cut out for a second. You said, how have I found the connectome? And then it cut out for a second.
Oh, sorry. How is it affecting your awake craniotomies and stimulation? Are you finding you're doing less of those and relying more on the on the connectome data, or they're complementary, or what trends are you seeing there?
Well, I think the answer is this: we don't know enough about what the connectome, what's essential, and how do we know to put the stimulator away for speech and motor. And having said that, what I found, what made me a believer on this, is that generally, once I really understood what tracks were doing, the intraoperative events started becoming obvious. So if a patient struggles speaking and I'm nowhere near the language areas, I generally assume that, well, that's probably nothing, or it's something attached to something that's pulling on the language area, like in a redo case. I think that what it does make you is very fast and confident, because you know what you're here to do. You know where the anatomy is, so you know where I'm going to go look first, and so there's not as much mystery. And especially when you're doing the subcortical regions, you just know about where the tracks are going to be. Having said that, I don't think that most people, at least to me, are doing a really compelling job at doing awake surgery to preserve really complex cognition. I know people are doing stimulation in the operating room. My experience is that where people who do intraoperative stimulation are attributing things like theory of mind or other higher cognitive functions tends to really contradict all the science of what part of the brain does that. So it's possible that someone sticking an electrode into the brain and someone who's awake is doing an intraoperative test that's possible to do with your head open, are just learning something that we don't know. But I'm think more likely that the intraoperative tests just aren't reliable enough for us to be tailoring our extent of resection based on it. And I'm basing this on, I did a lot of these cases. I tried to go in and do this. And at least in my hands, I just didn't get information that I thought was reliable enough to say, I'm going to leave this tumor here for this reason. And so what the real benefit of it is that in one area, it makes you a little bit faster at doing awake surgery. But when you go into places like the frontal pole, most people aren't really doing awakes there, because we don't really know what do you do exactly, like what's the frontal polar test. And some people have proposed this, but the truth is, I think the better bet is to just not destroy the anatomy that we think probably does that, and you'll probably have better outcomes. Remains to be seen, but I think that in general, if you save the networks, in my experience, you save the default mode network, you see a lot fewer problems.
Great, thanks.
All right.
Well, Mike, I think our time is up, but it's a fantastic run through and a really neat, really nice ideas, and you're developing it in a very logical and systematic, usable fashion. And then anyone who has other question or issue, we can get your contact into it as needed, and I'm sure you'll be talking to Raphael in the future. So anything else, just thanks very, very much.
Yeah, thanks guys for having me.
Yep, thank you.
Thank you.
Thanks.